This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we have our Dr. Wissam Jabber, who's one of our really fine interventional cardiologists who's based primarily at Midtown, also helps out at Grady, and is, as I said, one of our really fine interventional cardiologists, known not only for his technical abilities, but for his fantastic teaching skills, and is highly regarded by our fellows. Wissam, originally from Lebanon, did his medical school at Emory's Extension East, American University Beirut, and did some initial training there, and then did residency at Duke, and then subsequent fellowship at Mayo Clinic. He then got to spend some great time, quality time, in the wilds of Iowa, right? Dealing with those wonderful issues that we know that are related to our immigration service, getting visas straight, and we were really fortunate to be able to recruit him to the faculty after that, and again, based primarily at Midtown. He's really had some great contributions to the division, both as an interventionalist and as a teacher. Not that those are exclusive, I guess those sometimes go together, huh? Interventionalist and a teacher, and has been involved in our pulmonary embolus program, and today he's going to talk about one of the challenging, new, and exciting areas in interventional cardiology, chronic total occlusions. And he's going to tell us whether it's worth it or not, huh?
Yeah, I think it is.
You think it is? Okay, that's the answer, huh? Okay, welcome.
Thank you. I'm sorry. Thanks, Dr. Taylor. Good morning, everybody. So we'll be talking today, like Dr. Taylor said, about chronic total occlusions. The reason we're talking about that from an interventional standpoint is the fact that CTOs, or chronic total occlusions, have traditionally been the weak point in interventional cardiology with traditionally low success rate. But several years ago, the Japanese have started new techniques, including retrograde canalization and dissection re-entry. And these have been streamlined now in the United States, and the success rate has increased significantly. So what we'll be talking about today is some of that, and we'll be mentioning, we'll be talking about definition of CTO initially. Then I'll be making the argument as to why we should probably intervene more often on those CTOs, and talk about some patient selection, who should intervene on these CTOs, and then show some cases and the new techniques. We started the programs here a few years ago at Emory Midtown and here at EUH, and a lot of the success of the program has been attributed to big help from Bill Nicholson, who's sitting here. He's a national expert in CTOs. Thanks, Bill. Now I'll start with a couple cases. This is the first patient, 66-year-old man with hypertension and dyslipidemia. He was treated for several years for angina. He's known with an occluded circumflex, treated medically. His anti-anginals are coupled atenolol and amlodipine. He could not really tolerate isosorbide. He has class 2 angina, but when you ask him, he says he's tired. He has some dyspnea on exertion. This is his coronary anatomy. He has a circumflex that's occluded here. You can see collaterals down in that distal circumflex. The operator we actually tried to put a wire in this guy, and then you can notice here that the wire trying to intervene on him because he thought he was not doing well. The wire here going in the circumflex proximal cap, you see that the wire is not going to where the lumen we think is, trying to redirect it, but then the wire here is in a dissection plane. Now, traditionally in the past, with such intervention, we used to give this up and keep treating the patient medically and maybe send him to bypass if he's very symptomatic. This guy was not very symptomatic. But these days we try newer techniques, and if you stick around, I'll show you how we treated this guy later on. A second patient is a 53-year-old man with class 3 angina for 6 months. He has history of hypertension, smoker. He's on lisinopril and aspirin, and he had a stress test that showed inferior ischemia. He was started on metoprolol and atorvastatin, and he was referred for cath. And that's his cath. So you see here, this is the right coronary artery. You see the mid-RCA is occluded here after the RV branch. There's a little channel in it, but you lose the artery somewhere there, and it's diffuse disease all the way down. You see collaterals down there. Now, the operator who did this tried to put a wire in this artery, but the wire kept sliding into the RV branch, and when the wire hooked up this mid-RCA, it wouldn't go anywhere. So the question is, they stopped. They started him on isosorbide, and then a month later, he was doing better. He had mild angina, but he gave up hard activity. So the question is, should he be referred to cabbage? Should you reattempt PCI, and what technique to use? I'll also show the resolution of this case later. Now, I'll start with the definition of CTO. And by definition, a CTO, chronic total occlusion, is 100% angiographic occlusion in the coronary arteries for at least 3 months. And how can we tell 3 months? Usually by symptoms, or if they've had an older angiogram or history of MI. Now, the questions are, is it common? And how is it being treated? And is it worth treating percutaneously is what I'm going to be discussing. Now, how prevalent are CTOs? In a Canadian multi-center registry of 14,000 patients undergoing cath in 2008 and 2009, the proportion of patients with at least one CTO on coronary angiogram was 20% of all CAD patients and 54% if the patients have had prior cabbage. So it's a common disease. And the question is, how is it being treated? From the Berry Registry sub-study, if you look at how often these patients are treated with PCI in dark blue, that's a little bit over 10% of these patients treated with PCI versus the non-CTOs in that sub-study, and they were treated more than 35% of time with PCI. Now, most of the ones with CTO are treated medically. Not that that's wrong, but there's a big discrepancy between the way CTOs are treated and non-CTOs are treated. Now, this is probably related to some factors. I called it misconception, but a lot of them have some truth to them. So the first one is, traditionally we think about PCI as frequently unsuccessful in CTOs. We also traditionally thought as PCI, or some people think about PCI as too risky in these patients. Common thought also is CTO is not dangerous. We tell frequently the patient, well, the artery is 100% closed, what worse is going to happen? And we frequently assume that when we see good collaterals by angiogram, that there's very good perfusion distally. And thus, we think frequently that PCI is usually not indicated in these cases. Now, these are not without merit, and that's true because traditionally, and this is data from the Mayo Clinic over the last 3 decades, traditionally the success rate of PCI has been low. In the past, it used to be about 50%, and in good hands, it has remained around 70% over a couple decades from the 90s. And if you compare that to non-CTO PCI, you can see why we feel that CTOs are difficult. The success rate of non-CTO PCI is up to 98% or even more. This is a little older data, but how are we doing now? This is a recent article by Manos Brilakis in Dallas. And looking at the NCDR registry between 2009 and 2013, and this is all participating centers who have done at least 10 CTOs a year. And if you look at the median success rate is still quite low, around in the 50%. Now, when interventionists see this, you can understand why interventionists look at CTOs as the fox looks at the grapes in Aesop's fable. We look at a CTO is not very attainable. Well, it's not that bad. Let's leave it alone. Let's treat it medically. It's not going to get any worse. But is having a CTO a bad thing? That's the question. And can a CTO lesion get worse? Now, first, if you look at a histologic study about what a CTO is, you're going to notice that in one of the autopsy studies, looking at all CTOs, 78% of them of angiographic CTOs were not totally occluded by histology. They frequently had some neovascular channels in the central lumen, intimal plaque, or adventitia, such that a lot of these lesions had histologically anywhere between 90 and 99% stenosis. So if you compare that to non-CTOs, and if you find a lesion that's 95 or 99%, we frequently err on the side of intervention. So these can potentially get worse. How about symptoms? Do patients with CTO have symptoms? If we go back to the Canadian registry, those 20% of patients with CTO, 87% had more than mild angina, class 2 or more. So these patients do have symptoms. And we know from studies that if you intervene on these lesions, you're going to help the patient with both symptoms, angina frequency, and physical limitation, and quality of life. Now, the second question is, do the patients with CTO have ischemia? And this has been studied. There were a couple studies on FFR in patients with CTO. This is a study on 107 patients with CTOs who had a pressure wire placed distally after crossing the lesion but before intervening on it. And in all these cases, the FFR was less than 0.8, which means that all patients with CTO had ischemic distal territory, and that was regardless of the presence of good collaterals. So that conception that if we have good collaterals, it means the perfusion is good, is probably not true because all these patients still have an abnormal FFR. And we're all familiar with the COURAGE nuclear substudy that showed that higher ischemic burden is associated with mortality. And patients with more than 5% reduction in their ischemic myocardium with intervention have better survival than patients who did not have significant reduction in their ischemia. And also patients who have residual ischemia post-treatment, the worse the ischemia is, the worse the mortality. And we also know from the study that reduction of ischemic burden was higher with PCI compared to medical therapy. Now, that may partly explain why in studies in CTO, and that COURAGE sub-study was not necessarily in CTOs, but if we look at the CTO population, there has been several studies looking at mortality with intervention. And in these patients, in this study, looking at CTO patients who had successful versus unsuccessful PCI, patients with successful PCI had better long-term survival than patients with unsuccessful PCI. Now, that's obviously not a randomized trial, and we don't have any randomized trial on the topic, but we have enough studies pointing towards the same direction. And if you compare the patients, this slide is not shown very well, but there's a line here. If you compare the patients with successful CTO PCI to patients with non-CTO elective PCI, their curves are similar, and both of these curves are lower than unsuccessful CTO PCI. And this remains true even after adjustment for baseline characteristics, including age, previous CABG, previous MI, ejection fraction, and renal insufficiency. It seems that success remains an independent predictor of survival in these patients. Even if we look at patients with good collaterals, and there are some studies looking at that, this study looked at improved survival. This study looks at revascularization in CTOs with well-developed collaterals, and it seems like we're seeing the same signal. If you look at the total population of patients who have had successful intervention, and you compare it to patients with medical therapy, they had better survival, and also better survival free of major cardiac events. Now, that leads me into the idea of complete revascularization. So maybe what's helping these patients is the fact that they're having complete revascularization. If you look at the Syntax trial, which is a trial, randomized trial of Taxus drug-eluting stent, first-generation drug-eluting stent versus bypass surgery in multivessel disease, when they looked at the residual Syntax score, which reflects the complexity and the amount of myocardium that was not revascularized, the number of arteries that were not revascularized, and the higher the Syntax score in these slides means the more the vessels that are not revascularized and the more complex the disease is. If you look at the purple line, which is the higher score, these patients had higher mortality on long-term follow-up, and that was irrespective of the baseline Syntax score, how complex the disease was at baseline. Not surprisingly, the presence of chronic total occlusion was the strongest predictor of incomplete revascularization. There's another thought also about opening CTOs in patients with reduced ejection fraction that maybe if you have a viable myocardium and you improve the perfusion, you will have an improvement in ejection fraction. This is a small MRI study showing that in patients who have had CTO revascularization, 6 months, 5 months later, and at 3 years, the ejection fraction improved and the wall motion improved, but only in patients and mostly in patients who have the least infarct. And that makes sense. We want to revascularize areas that are viable. So in summary, who are the candidates for CTO PCI? We're thinking mostly about the symptomatic patients, obviously. We want to help them feel better on maximal medical therapy. But also we can consider large ischemia and high-risk stress test, even if they're asymptomatic, possibly because of survival benefit. Obviously, there's no trials on that, but that follows guidelines from AUC for non-CTO lesions. if you have very high risk stress test and high ischemia, that would be justifiable to intervene on. Obviously, we want to intervene on viable myocardium, question of LV dysfunction for improvement in ejection fraction, and that's these, I put a question mark because these are debatable. And the question of complete revascularization. So when you see patients with non-STEMI or angina, you find a 90% circumflex, a 100% RCA, we probably should intervene on both for complete revascularization. But again, this is not well studied. Now, I want to mention the OAT trial because the reason I mention it is frequently people mention that as a reason why not to intervene on CTOs. It's important to remember that this population is different. OAT trial, as a reminder, was in patients with an acute myocardial infarction who was not treated with primary PCI, and they were randomized for PCI of their totally occluded infarct-related artery versus medical therapy alone. And there was no difference in death, MI, or heart failure at 4 years. Now, this was in patients who had PCI 3 to 28 days post-infarct, so this is not a CTO. And also in the study, patients with angina were excluded, and patients with severe ischemia on stress tests were also excluded. And these are usually the patients that we treat when we're treating chronic total occlusions. How about bypass surgery for chronic total occlusion? Now, there are two types of populations here. The patients with a single vessel disease, CTO, unless it's a proximal LAD, you probably want to try to intervene on it percutaneously if you have a good success rate, rather than send them to surgery. But in patients with multi-vessel disease, even if you send them to surgery based on the syntax trial, 32% of CTOs randomized to bypass were not, in patients randomized to bypass, were actually not bypassed. So still, the bypass rate in these patients are not high. And if you look at a graft patency in the Prague 4 trial, and other trials have shown better patency than this, but in general, it's still not great. The patency of grafts to the RCA or other branches other than LAD at 1 year was quite low in CTO patients, as opposed to 100% in the LAD. So if you have somebody with proximal LAD, CTO, and you want to put a lima to LAD, then that's a great thing. But in other arteries, surgery may not always be the best option, except if patients maybe have multi-vessel disease, send them to bypass, but frequently that artery will be occluded, will remain occluded. And the reason for that is probably that those arteries downstream from the occlusion are negatively remodeled and diffusely diseased. This is why maybe the surgery doesn't take well. This is a study, this is an IVUS study presented at Euro Interventions. If you look at this LAD here treated after a CTO, you see that the artery there is very diffusely diseased, and we frequently see that after we treat a CTO, an artery that's diffusely diseased and small, and people would wonder, why did we open this artery? In this study, they did an IVUS immediately after this intervention, and you see how the artery distally is very diseased and small. But then when you bring the patient back several months later, you see how this artery now looks much plumber. It has regained some of its original size, and by IVUS study, you see how the artery now almost doubled. Now, this is probably an exaggerated case, but we frequently see these where the artery gets better down the road. Now that we've talked about these CTOs, how are we doing currently in the United States with CTOs? Here, this is the same NCDR registry study by Brulakis. And if you look at all the procedures done on CTO, on coronary disease, only 3.8% of these procedures are done on CTO. So that is much lower than the 20% prevalence of CTO in these cases. We've seen this picture before. We've seen the median success rate in the 50 percentile, but you see also some centers and some operators that have very high success rate. And if you look at the distribution is, there's a big distribution around this median, and there are some operators in the country that have achieved 90%, around 90%, or even more than 90% success rate. And the story boils down to how many cases they do and the techniques probably they use. But based on this study, the higher the mean annual CTO volume, the better the success rate, and also the lower the MACE rate is. And currently, with newer techniques and in expert hands and in experienced people, the success rate is closer to 90 or more than 90%. Now let's go back to this first patient, the 66-year-old man who had mild angina, had fatigue, and dyspnea on exertion. We frequently see this dyspnea on exertion sometimes in these patients that can improve after intervention with the occluded circumflex. I showed you the wire here not going down to where the artery is. And here the wire, you can see it in a dissection plane. This is the true lumen, but this is a branch of the artery. This is the artery we want to achieve, and this is in a dissection plane. Now, in the past, we used to give these up, but these days, if we're in a dissection plane, we actually use that to try to re-enter the artery distally. Now, this is a cartoon showing that if we trying to intervene on a lesion, ideally want to go through the lumen and want to cross the lesion into the distal lumen without having to dissect the artery. But in some cases where we're unable to do that, or if we, by mistake, or if the wire goes in the dissection plane, we don't give that up. We just take that dissection plane. The catheter you're seeing here is a blunt dissection catheter called the crossbars. And then what it does is that, or what we do sometimes with the wire, is we go outside the intima, into the subintimal space, and then we advance a blunt dissection up to the distal lumen. Then this catheter is removed, and we try to re-enter the lumen with a catheter called Stingray. This is a catheter with a couple balloons on it that flatten the catheter in the middle of the artery. And in the belly of this catheter, there's a hole on either side that allows a stiff wire to puncture the intima back into the true lumen. And we call this dissection re-entry. And then the catheter is removed, and then we continue with intervention, ballooning, and stenting. So in this case, you see here, this is the projection of the balloon between the two dots, and it's facing the true lumen that's being filled with collaterals. And then the wire will poke the side of the balloon down into the distal lumen. You see how it's coming out at the side of the balloon. And now the wire is in the true lumen. And then we continue with the case over that wire with the regular stenting. And this is the final result of this patient. The patient did very well, and he was asymptomatic on follow-up. This is another example of dissection re-entry. This is a mid-LAD where you see the artery distally. You see it, you don't see it very well. Somebody with symptoms and occluded LAD in the mid-segment. This patient was tried before and intervention was failed, so we always plan to try to go back through the true lumen, but if we don't, and if we're outside the vessel, and this is an example of how we can tell we're outside the vessel, this is a wire here, and you can see where the lumen is, and the wire is outside here in the dissection plane. This is the Stingray catheter. The true lumen is here, and this is the wire trying to enter the true lumen. You see how it's coming out from the side of the balloon, and then it enters the lumen distally. And then we continue with intervention, stenting, and part of the stent will be in a dissection plane. Now we're back to the patient number 2, 53-year-old man with angina. He had inferior ischemia. He's on metoprolol and isosorbide, and he has failed attempt at RCA intervention. Now I showed you the dissection re-entry, but frequently we also do what we call retrograde catheterization. So here, if you look at the distal target, we have a distal PDA that we can probably access using septal arteries. We try initially to go and integrate, but if that fails, and if the artery doesn't look very good distally for re-entry, we try to use the retrograde. In most of these cases, we put 2 guiding catheters, one in the right coronary artery, one in the left artery. And what we're trying to do is we're trying to visualize the distal vessel with collateral visualization, or we're trying to cross these collaterals into the distal vessel. And in this case, if you look at the LAD, it had nice septal collaterals. Most of the collaterals we use, most of the collaterals we use are usually septals because these are safe collaterals to cross. If we rupture these collaterals, nothing big is going to happen most of the time. You're going to have a little hematoma in the myocardium. So here you see the wire going through that septal, going down towards the PDA. You see the wire here crossing down into the distal right coronary artery, going through the guide. And then this is usually followed by a micro catheter into the distal RCA to allow to exchange wires and to give support. And you see the wire here initially going in a dissection plane, but then finding the lumen again in the proximal RCA. And what we try to do then with this wire is for this wire to meet that guide, and then this wire is externalized through this guide. Now obviously we cannot send stents, bulky stents inside those tiny collaterals, septal collaterals. So what we do is we externalize this wire, which means we send a long wire up into from the other side of the other arteriotomy site, and then we use this wire to send our gear downstream and fix the artery. And in this case, then we used that wire and treated that RCA, and this is the final result. We don't always use septals to go from LAD to RCA or RCA to LAD. This is an example of a patient of mine. This is a very nice guy with COPD who was not a surgical candidate but had significant angina. You see the LAD here occluded in the mid-segment. This is a diagonal, a septal, and then the LAD is lost. There's some channels in the middle, and his RCA is also occluded. So we talked to surgeons, and he was not a surgical candidate. They did not think his COPD was actually too bad. So here we tried, obviously, to intervene on him any grade. And if you go back to these cases, a lot of these occlusions, they appear as if they're subtotally occluded, as if there's a channel in them. But frequently you go in, and it's very hard to intervene on. And in this LAD, spent a lot of time, and the wire would always go somewhere else, either in septals, go in diagonals, but never met the LAD distally. Now we can try purposefully to dissect and re-enter distally, but in this case, we notice that there's a big septal here coming proximally, going down, and then this septal goes back up to fill the distal LAD. So what we did is we used that channel to go retrograde in the LAD, and you see the catheter here going through it. That's the microcatheter going back up into the distal LAD, and then we poke the lesion from the distal cap, which is usually softer than the proximal cap. You see the wire here being sent retrograde, and then the wire was extended all the way up into the left main, up in the aorta. So that's a wire that goes into the LAD, down the septal, up the LAD, and up into the aorta. And you see a catheter here coming from the radial artery with a snare to snare the wire, and that wire is then externalized from the radial artery, and the intervention is continued on this LAD, and then this is a stent in it, and this is the final result. Now this guy was brought also later, we don't do it in the same setting, brought later for the RCA CTO, and although this seems to be a very long CTO, in fact, we could cross it just in the true lumen and not do any complex procedures. And this happens in about maybe 50% of the time in CTOs. Another 50%, we have to do that dissection, re-entry, or retrograde. And this is his final result. He did great afterwards, except for his COPD, of course. Now, the last technique that I'm going to mention is retrograde dissection. And re-entry, we call it reverse card. This is a patient of mine also who is 62. He has had recurrent VTs and had class 2 angina. He has a history of lateral infarct. You see an ICD here, and because of his recurrent VTs, we decided that maybe we need to treat his distal circumflex. Now, the problem here is that OM is occluded at the ostium, so you don't really see very well where it starts. And there is a ramus here. There's a lesion, but this was FFR, it was negative. There's a ramus here that gives collaterals here, epicardial collaterals to this vessel. Now, we tried, obviously, initially to put a wire in, but the wire wouldn't go anywhere. There's a lot of calcium, and we couldn't access this artery. So what we use is we noticed that there's nice collaterals here. Now, these are epicardial collaterals, and epicardial collaterals are more risky to go through. We use them, but we have to be very careful about rupture because they can cause tamponade. And so what we did is we used the wire, crossed this septal, crossed this collateral, and you see the wire here in the distal obtuse marginal. There's a microcatheter that follows it. Then you see the wire going backwards. The wire going all the way back to that wire, but the wires wouldn't meet. So tried a lot, and the wires wouldn't meet. They're in two different planes, probably because of the calcium sitting in there or other reasons, but the wires are in different planes, and we could not access the true lumen going retrograde. In these cases, we do what we call reverse cart, reverse controlled dissection re-entry. So what we try to do, the principle is to try to dissect any grade, so we go outside the lumen any grade and retrograde. Sometimes these wires meet, but occasionally they don't meet. They're in different planes. So what we do is we balloon the any-grade wire. We balloon the dissection plane to try to make it bigger and make these two wires meet. And once they meet, we sometimes advance an extension catheter, like a Guidezilla or a Guideliner, and advance the distal wire into it to try to externalize it in the any-grade catheter. You see here a wire trying to dissect this artery any grade. We formed a loop with the wire, and that's in a dissection plane, but they're not in the same plane. This is a guideliner trying to advance it down. This is a balloon in the antegrade wire. And you see that now that the balloon is meeting that other catheter. And then that allowed for the retrograde wire to be externalized through a different catheter here in the left main. So now we have a wire going into this catheter, crossing the lesion, and we can use this wire to complete the intervention. And this is his result. Notice that this artery looks relatively small and diseased, but we frequently see that at the end of cases, and they probably get bigger later on. Now, this guy had significant angina improvement, but his VT did not improve. I guess this is coming. He was ablated multiple times. Now that we've seen these techniques, what's the outcome and safety of CTO PCI with these techniques? This is a study, a long-term outcome of percutaneous coronary intervention for chronic total occlusion, and these are older data. So these are not exactly with these techniques, but if we're looking at chronic stents and how these stents behave, if we look at restenosis and cumulative target vessel revascularization, with bare metal stents, it's 30% at 5 years, which probably similar or maybe a little higher than non-CTO PCIs. If you look at the drug-eluting stents, and most of these stents in this trial were older generation drug-eluting stents, it's up to 17% at 5 years, which is expected. So probably the CTO is not causing much more restenosis than we usually see. If we look at stent thrombosis, it's also similar to what we see in non-CTO lesions. Now, with newer generation stents, the restenosis rate is probably less. And in this European experience with the new Resolute stent, it's down to about 12%. In a better conducted study, in the Science study, safety and effectiveness of Science stents in chronic total coronary occlusion revascularization of 250 patients enrolled prospectively, 80% of these were antegrade. So these are with the newer approaches. The target lesion revascularization at 1 year was only 6.3%, and the definite stent thrombosis was 0.9%. So that's very comparable to what we see in other lesions. Probably the restenosis is a little higher than other lesions, and the reason for that most of the time is the length of the stents we have to use in these long lesions, probably rather than the technique itself. In the European experience of retrograde recanalization, and these are the more complex cases, in retrograde recanalization in the European registry, up at 2 years, MACE was in successful PCI 8.7%. The cardiac death, MI, and strokes are low, and the revascularization was successful PCI 8.6% at 2 years. So that's a good number. That's very comparable to other interventions. But notice always the unsuccessful PCI, they don't do as well. So we always see that hint in all these studies that these patients do much worse on follow-up than patients who have successful revascularization. And the percent success in retrograde recanalization was about 80%, 81%. And it increased over years. It included a lot of centers. Some of them did not have experience early on. But it started at 70%, increased to 80%. And these are only the retrograde recanalization. We're not talking about the antegrade, which had higher success rates. And in this same study, looking at patients' symptoms up to more than 3 years, from baseline to 3-month follow-up and to 3 years follow-up, there has been significant improvement in angina that persisted after 3 years, and also improvement in the dyspnea. And we see that sometimes these patients do not complain a lot of angina. They adjust their lifestyle, but they don't feel good. They have little dyspnea and fatigue. How about complications? Now, the usual complications that can happen with any interventions, MI, stroke, death, emergency bypass, are probably maybe slightly higher than other interventions just because it's a long procedure and it's more involved. But some other issues with this intervention are perforations, which are more common, although most of the time they don't lead into anything serious. Radiation exposure, they clearly have more radiation because it's a longer procedure, and contrast volume. If we look at a meta-analysis of 18,000 patients from 65 studies, and that included a lot of studies even early on before the newer advances. If we look at the MACE rate, death, emergency CABG, and strokes, and all these, they're probably a little similar, maybe slightly higher, but they're still than other non-CTO interventions. But they're low in general. If you look at perforation, is elevated in these cases, and unsuccessful is up to 10%, but most of them, in the successful, for example, it's 0. Most of them did not lead to tamponade, and it's a low rate in unsuccessful. The death rate is quite low. So these are generally safe, especially with experienced people. In this meta-analysis, and again, these are a lot of studies, not just the expert CTO operators in the country. If you look at the study publication year, you can see that the success rate has been climbing, and the most recent studies show a success rate of 80% or more, and the complication rate has been dropping. Now, the key to high success and low complications is case selection. So we want to make sure that we're selecting the right cases, a dedicated CTO program, and dedicated operators that have high volume and that are experienced with the newest techniques. We strive at reducing radiation in these cases. We try to reduce contrast volume as much as we can. Now, there are some ongoing trials. Now, obviously, this field lacks data, and there are some ongoing trials. A couple of trials, one this done in East Asia out of Korea, and this one in Europe. They're trying to randomize patients with CTOs to drug-eluting stents versus medical therapy, and the outcome is long-term at 3 years, both symptoms and hard outcomes, death and MI, but also quality of life. Now, this last study was just presented at TCT. It's Zion's study, Zion's stent for left ventricular function. These are patients who came in with STEMI, and they were treated for their STEMI, but they had another non-infarct-related artery that was 100% occluded. And the study wanted to randomize these patients to intervention versus no intervention, thinking that the ejection fraction would improve down the road. Now, the study presented was negative. The ejection fraction did not improve, but there was a signal that if the LAD is the CTO vessel, then maybe ejection fraction improves. I'm not going to discuss it more in details. It has not been published yet. So in summary, the CTO lesions are common with frequent angina. CTO intervention can be highly successful with low complication rate with experienced operators using new techniques. CTO interventions reduce angina and improve quality of life. And CTO interventions may improve survival in EF, and that's question mark may, in the presence of large ischemia and viable myocardium. Now, I'm going to pass it to Habib, who has been doing CTOs here at EUH, and he's going to talk more about the program here. Thanks, Habib.
Thank you, Wissam, for that great overview. What we thought we'd do is just take a few minutes to describe the Emory's CTO program, which a number of us got together. And frankly, we at Emory were part of the second wave of CTO operators. Bill Nicholson, who's here, has been one of our proctors for at least a couple of years. As many of you know, Bill is one of our ex-fellows, we like to proudly say, from 10, 12 years ago. But Bill is one of the premier international operators now in CTOs, and he's supported the program. I think for us, we wanted to be sure that the field was mature enough and the techniques were starting to get robust before we came on board. And also, as you saw, some of the data that Wissam presented, many of these papers were published in JACC Interventions, and want to hats off to our editor-in-chief who's in the room, who really has been very careful in shepherding this field forward and to be sure that we have data. Now, as far as Emory goes, what I want to do is share with you just, first of all, our volume of cases. This is where we were in terms of our volume of cases, and frankly, where many people were back in 2011. I should also mention that prior to that, Emory was known as a CTO site, and Dr. Douglas, used to get a lot of referrals, and we were very careful with case selection using the antegrade wire escalation techniques. And as Wissam mentioned, the dissection reentry techniques and the retrograde techniques have really allowed more successful cases. And so we've been very careful in patient selection. You can see that our volume of cases have steadily grown as the CTO program has unfolded. The CTO program at Emory and Midtown have not only involved proctors, but very careful programs where patients come in on the same day. We have 2 or 3 hours set aside for them. And then there's been intense focus on radiation reduction, contrast reduction, in order to make these cases successful. These data were generated, by the way, by Farshad, who's one of our cardiology fellows and is going to be an interventional fellow, and these data come from the NCDR registry. You can see that steady progression in 2015. We're not complete with 2015. We expect our numbers to be closer to 150 Today we're doing 5 cases here, and on Thursday we're doing another 2 or 3. So in a very careful way, we're growing the program across campuses. These are data generated again by Farshad. You can see that if you look at our own data, and by the way, let me tell you that our total number of cases in the last 4 or 5 years is about 450. And I think if we're at about 150 cases a year, that puts us into very good volume in terms of how we do nationally compared to other academic centers. Okay, who are the patients that we perform these procedures? Some of them were asymptomatic, and this was probably lack of angina, but hopefully they had dyspnea, and we're digging into these data. But I would say the majority of our cases were fairly symptomatic patients. Now, you might say, wow, they had class 4 angina. These were unstable angina. How could this be a CTO? But I think this is based on the NCDR definition of a change in anginal pattern or anginal frequency. So I feel like we're somewhat reassured that we're attempting these procedures on the right patients. As with many other registries, we noticed that a good chunk of our patients are right coronaries and LAD distributions, and a few left mains. And then we were pleased to see that our fluoroscopy times have reduced. And you might say, well, you're still pretty high with a median fluoro time in the 40-minute range. Remember that part of the changes we've done is we've reduced our fluoro frame rates from 15 frames per second down to 7.5 frames per second. And we've also reduced our fluoro pulse dose so that overall the same 1 minute of fluoro gives you a quarter of the radiation that it used to. And so what we're using now are the air karma measured in milligrays, and we have very, very firm cutoffs as to when we stop. And as Bill can attest, we've really reduced that dramatically here. Similarly, our contrast volumes are being followed very closely. And then we're also going to follow our procedural outcomes and other data that we're going to describe to you over the next years. But I think that a big thank you to all the cath lab staff who have taken us through the learning process and Bill and other programmatic improvements that we've made to make this a success. So I'll stop here and have Wissam back take some questions.
Okay, well, thanks for a very interesting talk. I'll start the questions off. So do we really have the right study coming down the pike to tell us whether this is worth doing? As you presented those studies that are just released or in progress when, with death or LV function as endpoints, I mean, my guess as an outsider looking in is that those aren't probably the most robust, probably not what you're going for most of the time. You're trying to treat symptoms and angioplasty has a little bit of a history there with mortality as an endpoint in similar settings. So, I mean, do we have the right study coming down the pike? And if not, what are the chances that we can? Because that's the crux of the issue, right? Is to show that there's true value to this.
I agree with you. The studies being done now looking at hard outcome, focusing mostly on quality of life, actually. And you're right, in interventional field, we have not proven in any stable patient in an randomized trial that we reduce mortality in stable coronary disease by doing percutaneous coronary intervention. But in these cases, we focus mostly on patients with symptoms, and I think this is where most of the work is. And we probably don't need a lot of studies to show that if you have somebody on maximum medical management who still have angina and occluded vessel, that they get better with intervention. But the studies that are currently being done may answer some of this question, but probably hard mortality, we're not going to be able to document that anytime soon. Any comments from the audience?
I guess my question is which of you gave us several studies in progress? Were any of those really going to help us with the quality of life or symptoms question?
Yeah, both studies done in Asia and in Europe have a quality of life as an outcome at 3 years. So they're looking at long-term results, but we're not going to have any results from these anytime soon. They're just ongoing right now.
Open questions?
That was great. That study
Thank you.
from, that was reported at TCT about acute infarction, as I recall, what they were doing, they were looking at change in ejection fraction, right? As an endpoint. And post-MI, change of ejection fraction would be an interesting surrogate endpoint, I think. But as I remember, they didn't show a difference overall, but with the it generated this hypothesis that maybe this ought to be looked at specific for LAD because they did see an improvement in ejection fraction doing LAD. I mean, in the regular practice, how much emphasis is put on what artery is involved and as to, you know, are the chances if we can open chronic total occlusions LAD is similar to putting a lima in the LAD, we may do a heck of a lot better than the total group. Should this be targeted in future studies?
I agree with you that LAD probably should be looked at differently. In this study, LAD patients with, like you mentioned, with LAD occlusion did better if they were intervened on, or at least there was a signal that they were doing better if they were intervened on. In general, in our practice, we have a proximal LAD occlusion. We have excellent surgeons. We tend to send them for lima to LAD. And I think that's more long-term option for these patients. So most of the CTOs being done actually 50 or 60% are on RCAs. We have some done on circumflex, some done on LAD. Most of these are mid-LAD or proximal LAD if the patient is not a surgical candidate or the LAD is very small. But anytime we see a decent LAD distally, we almost always send them to bypass.
So this does inhibit good surgery does inhibit your ability to study this a little bit in this country. Other places don't have that problem because they're not doing much surgery.
We got two questions which are related online there. You can see one is a difference between male versus female and success rates, and from the Emory data, any information regarding age and gender impact.
I'm not aware of any gender difference in success rates. I don't know if Habib or Bill are aware of any gender difference in success rate, not to my knowledge.
That's being looked at in open CTO, so that's one of the sub-studies.
Bill is saying this is one of the sub-studies in open CTO that's going to come out. It's being looked at, but there's no data yet on that information.
Look at that in our database.
Yeah, we don't have the answer from our data either.
Is there any, you would think that if you could sort out how much myocardial mass is involved in the CTO, that you might be able to sort out which patients would be appropriately treated, and I wondered whether that's been looked at.
Habib is answering the question.
Yeah, so there was a nice paper by the Mid-America group where they looked at the ischemic burden. And as I recall from Aaron Grantham's group, they found that if you have more than 15% ischemia, that you were more likely with a CTO PCI to get relief of ischemia, and that was associated with better outcomes. So as you might expect, the larger amount of territory at risk, the more the potential benefit. I think that...
Is there a converse, that is, if the ischemic burden... Is there a converse, and that is if the ischemic burden is only 5% or less or 10% or less, then you don't have results that are worth tackling that CTO?
Absolutely, yeah. If the ischemic burden is less than 5%, particularly in that study, they didn't notice a difference. And there's also some MRI data along those lines, one of which Wissam showed, that if you have a large area of burden, predominantly viable, that those patients tend to derive benefit. I think I just want to make a comment about a randomized trial because, and maybe Bill wants to comment on this because you're sort of in the inner circles, but you know, what are the risks and benefits of taking on a randomized trial? How would you design it? Obviously, the trick is that a lot of CTO patients have multivessel disease. And in fact, the FAME-3 trial, which by the way, we're just starting across Emory, is a randomized trial of functional PCI versus bypass surgery. It's an international trial, and there was a lot of discussion at the investigators meeting whether to make a large CTO component of that. Multivessel disease with CTO, without CTO, or do you take on a randomized trial of single vessel disease of CTO PCI versus medical therapy. What are your thoughts?
So it is going to happen. So theoretically, some of this is not to be disclosed just yet, but there is going to be a randomized trial to look specifically at CTO revascularization. And there's been a discussion of exactly what you're talking about, with whether you're going to look at multivessel disease and residual syntax scores when you're done revascularizing a patient, having a goal less than 8, and versus just doing a single vessel CTO in a patient that doesn't have other disease as well. I think it's going to be harder to prove things if you're going to go after single vessel disease. And I think what Dr. Guyton was referring to, when you get into these smaller vessels, anything that in my world, if you've got a small territory that's at risk, I think you have to have profound symptoms to really, warrant going after that patient. I do very, very, very little asymptomatic ischemic burden patients. So like if you come in with a, an ischemic territory, but you don't have symptoms or don't have significant symptoms on medical therapy, I don't do those patients. And proximal LADs and LAD territories are the only people that I really, in my mind, rationalize or justify that they should be treated. And I believe in revascularization. So it's not a competition by any stretch with surgery versus PCI. I'm still the #1 referrer to our surgeons. I still send more robotic Lima to the LADs than anybody in the practice. I think it's just a matter of how you're going to treat the patients. I think if they have profound symptoms, they have a chronically occluded vessel, they're fixable. And I think the discussion about symptomatic relief or not is over. If you look at, there's trial after, or study after study after study, that if you can recanalize the CTO segment, 87% of those patients have complete abolition of angina. So not get better, not feel better. I stopped their metoprolol, I stopped their ranolazine, I stopped their Imdor. They get better. That discussion's over, and I think mortality is always going to be a tough discussion in anything interventional cardiology related. But it goes back to the same thing. Why do they don't require you to show a mortality benefit to replace somebody's hip? So if the guy's disabled and he can't do anything, apparently hip surgery is just fine to do to get that guy back to a functional capacity. But if we put a stent in your coronary, we need to show that there's a survival benefit that comes along with that. And I'm not sure I've ever understood that kind of dichotomy. So I think if you're going to talk about survival benefit, that is what they're going for with this trial that's being designed. So it's going to be a randomized trial, medical therapy versus recanalization. They're going to have multiple endpoints, but survival benefits one of the things they're looking at. And if you look at the British registry, where they have upwards of 14,000 patients, there's a huge, profound difference between survival in those patients, whether they had successful or unsuccessful recanalization. So the unsuccessful group, it's a huge number. You're talking 20+% difference in those patients, survival. So it'd be interesting to see.
I think one more thing should be said about this survival thing, because it is the wrong endpoint. It should not be the endpoint for trials of CTO, because until we show survival benefit in stable ischemic heart disease overall, it's just, there's no rationale, there's no mechanistic reason that I can think of why CTO opening should generate a survival benefit, but opening everything else doesn't. And it's probably because the comparison on the CTO side has been successful versus unsuccessful. Well, unsuccessful things have many reasons. They might lead to a survival detriment. And so I think you're really on the right track, because you can cure angina with these people. The astonishing thing is that we used to think the success rate was 60%. Now we're convinced it's over 90. So it changes your whole attitude about doing these cases.
I think the other new opportunity we have for us is to reinvigorate the heart team for coronary revascularization, right? In the valve arena, I think we've done a fabulous job of that, and I know that Robert, you've kind of gotten our coronary surgeons, or Mike Halkos, all of you guys, but Mike is leading that, and Duke Wynn and others that are really sort of learning the new leading edge bypass techniques, including full arterial revascularization and obviously the hybrid work. I really think it's an opportunity for us, maybe this FAME3 trial, which is going to be ongoing in all 3 of our major campuses, to reinvigorate this idea that every multivessel disease patient should be considered by a group in the heart team. And then along those lines, in terms of who else is a CTO candidate, a lot of patients who undergo bypass surgery and they're 10 years out, their lima looks beautiful, but perhaps some of the other vein grafts are closed and then they have native disease. Those patients as well might benefit from CTO PCI. But even then, I think a heart team approach to consider redo bypass versus CTO PCI is the way to go.
One more typed in question there.
I'm not aware of any formal exercise capacity study in CTO versus optimal medical therapy. I don't know if you guys are aware of formally, informal. I mean, there are quality of life and angina questionnaires and symptom relief. Bill,
Very deeply looked at in open CTO. It's not going to answer that question about having CTO versus optimal medical therapy. I mean, it's going to look at people's functional capacity by real measurement scores pre and post treatment. But I don't know that we have one. It's a randomized trial I mean, there's no randomized trials out there really looking at CTO medical therapy versus revascularization. So.
All right. Well, thanks very much for a great talk and a fantastic discussion, everyone. Thanks so much.
The preceding program is copyrighted by Emory University.